If you have any questions, you can place them at the Q&A box and we will address them during the open forum after the lecture. You will receive your certificate of participation to this webinar a week after you submit the evaluation form and post-test. The link will be posted at the Q&A box and at the chat box midway through the webinar. This is the second of our 8-part LMLR series for this year. The LMLR lecture series hopes to continue the advocacy in teaching rheumatology to our colleagues initiated by the first Filipino rheumatologist, Dr. Lourdes Manahan. LMLR is in support of Sustainable Development Goal 3, Health and Well-being, and SDG 4, Quality Education of the WHO. The Division of Rheumatology is also happy to announce its publication of the Atlas of Rheumatic Diseases in the Philippines, and if you want to purchase a copy, the order form will be shared later. This is the second lecture of this year's LMLR webinar series, which focuses on the use of checkpoint inhibitors as treatment for cancer and rheumatic diseases that may arise from its use. The first of our distinguished speakers is Dr. Dennis Sacdalan. He completed his fellowship in medical oncology and his master's degree in clinical medicine in medical oncology at the UP-PGH. He trained on cancer prevention at the National Cancer Institute in Bethesda, Maryland. He is also a PhD candidate in molecular biology and biotechnology at UP Diliman. Dr. Sacdalan is the head of the Manila Med Cancer Center and is a member of the PGH Cancer Group. He is passionate in advancing oncology in the Philippines through his teaching and research, having participated in various clinical trials and published numerous research papers. Our second esteemed speaker is Dr. Kristina Rubio. She completed her fellowship in rheumatology at the Philippine General Hospital and pursued subspecialty training for inflammatory ultrasound at inflammatory arthritis and musculoskeletal ultrasound at the Johns Hopkins University in Baltimore, USA. She is the Vice President for Medical Affairs at Centre Medical International and is an active consultant at the Makati Medical Center, the Medical City, and VR Potenciano Hospital. Dr. Rubio followed the footsteps of her grand aunt, Dr. Lourdes Manahan, in contributing to the growth of knowledge in rheumatology through her publications on various inflammatory arthritis, vasculitis, and on the association of immune checkpoint inhibitors and rheumatic disorders. She recently served as the associate editor of the Lourdes Manahan Centennial Rheumatology issue of the Acta Medica Filipina, which features landmark research of Dr. Manahan and other research papers from the Division of Rheumatology. So let me now call to the stage, so to speak, first Dr. Sacdalan, and then Dr. Rubio to share their expertise in today's lecture.
Good afternoon. It is an honor to be invited to speak in the Lourdes Manahan Lectures, and I sincerely thank the Division of Rheumatology for having me here. Today, I will be discussing some principles behind this novel and increasingly popular strategy in the treatment of cancer, and hopefully you will be able to appreciate how this relates to rheumatology. These are my disclosures. My objectives for today are first, to discuss immune checkpoint inhibition as a therapeutic strategy in the treatment of cancer. Second, to enumerate the approved immune checkpoint inhibitors in the Philippines and in the world. And lastly, I just added this objective at the last minute, and that is to highlight immune-related adverse events as emerging phenomena associated with the use of this novel treatment. Now, a few years back, as a trainee in oncology, I used to think that oncology and rheumatology were two separate and distinct worlds. But over time, I learned that our subspecialties actually overlapped in more ways than one. Now, I'm quite a Marvel geek, so pardon this analogy. If you watched the recent Spider-Man movie No Way Home, you might find it similar to what was seen in the movie wherein a multiverse was merging into one. It can be quite exciting seeing features of different worlds coming together, but at the same time, it can become very problematic. Overlaps in oncology and rheumatology involve similar etiologies and clinical presentations of cancer and rheumatic diseases. Patients may present with bone and joint pains that are manifestations of bone metastases, or with connective tissue diseases that turn out to be paraneoplastic syndromes. The role of the immune system has also been found to be common between cancer and rheumatic diseases. For one, it is due to a defect in the immune system causing tumor cells to escape immunosurveillance, while for the other, it is due to an overreactive immune system. Also, some of the drugs that we use to treat cancer are also used in rheumatologic illnesses, such as methotrexate, cyclophosphamide, and rituximab. And now, with the emergence of immunotherapies, we see more and more immune-related adverse events that may be adequately co-managed by rheumatologists. So let's go straight to our agenda. We'll talk about the principles of immunotherapy and why it has become the standard of care, overshadowing the role of chemotherapy in oncology. If you have listened to my past talks on immunotherapy, you would probably be familiar with this figure. I'd like to make this analogy of cancer cells being like criminals, no? Mga pasaway. These are bad elements of the society or bad elements of the body, since they are not subject to normal cellular control mechanisms. They grow rapidly and tend to have an indefinite lifespan because they evade apoptosis. Because of the rapid rate of replication during the cell cycle, there is a high incidence of DNA mutations because of DNA repair mechanisms that cannot keep up with the speed of the cell cycle, or because of defects in the repair mechanisms. These mutations then lead to the expression of abnormal proteins on the surface of tumor cells. And these tumor cells, or rather these aberrant proteins, are usually recognized as foreign antigens. Because of these, tumor cells are then eliminated by the immune system in a process called immunosurveillance. In this process, it's like policemen who catch criminals and eliminate these bad elements from society. Now, there are times when tumor cells escape the roving eye of the policeman or the immune cells. And in the process called immunoediting, cancer cells can somehow tone down or modulate the immune response such that immune cells are able to recognize the cancer but do not tolerate or do not eliminate it. And this is some form of development of tolerance. What happens is that some tumor cells are killed while others, due to their low immunogenicity, escape immune surveillance and remain dormant. The problem with this is that these cells can divide and produce daughter cells that are less immunogenic due to immune-evasive mutations. And when more of these evasive tumor cells are produced, there is escape from the immunosurveillance. And like criminals that escape from jail, tumor cells are able to break free from immunosurveillance and can now freely roam around to metastasize to any part of the body. Now that we've understood how cancer develops in the context of the immune system, let's look at this figure, which shows us that there's more than one therapeutic approach to this problem. There are several strategies developed to overcome escape from immunosurveillance, and today we will just focus on one, and that is immune checkpoint inhibition, as you see here in the upper left figure. This involves the use of antibodies that do not attack the cancer cells, but rather improves or restores the immune response against tumor cells. So for the remainder of this talk, when I mention immunotherapy, I will be referring to immune checkpoint inhibitors. To better understand this, let's look at how balance is achieved in our immune system. T cells are typically activated in the presence of a foreign antigen including cancer antigens, through cell surface receptors. Normally, immune checkpoints serve as check and balance by preventing uncontrolled inflammation or autoimmune activity. They switch off or dampen T cell activity. And examples of these important molecules include CTLA4 and PD-1, which we will be taking up in a while. Cancers usually take advantage of these immune checkpoints in order to escape detection by T cells. So you can recognize a dendritic cell here, colored white, with its irregular surface and numerous projections, while over here is a T cell. After a dendritic cell, the most potent antigen-presenting cell, presents antigens to a T cell through the MHC molecule. It primes the T cell to eventually attack the tumor. Now, to serve as a regulator of response, we have the B7-1 and B7-2 molecules, colored purple. They're located on the surface of the antigen-presenting cell, and they bind to the CTLA4 molecule, colored blue over here, which is found on the surface of the T cell, leading to a dampening of T cell activity. Blocking the checkpoint CTLA4, as you see in this part of the illustration, is an inhibitor, or it's an antibody against CTLA4. And what this does is that it cancels the inactivation, making the T cell more active again against the cancer cell. During the effector phase of cellular immunity, activated cytotoxic T cells would normally kill tumor cells. However, tumors can still escape from death by deceiving T cells through an off switch. Binding of the PD-1 molecule, as you see here, on the surface of the T cell, to its ligand on the tumor cell, called the PD-L1 molecule, leads to another level of inactivation of the T cell. Similar to the previous slide, there are inhibitors of either PD-1 or PD-L1, as you see in this part of the illustration. And they preserve T cell cytotoxic activity by preventing the binding of these molecules. Now, we cannot discuss immune checkpoint inhibitors without talking about biomarkers. In the era of personalized medicine, it is quite important to select the right patients who will respond well to the most appropriate treatment based on the tumor profile or phenotype, especially if you will be using quite an expensive drug. Now, PD-L1 is just one of the biomarkers used for immune checkpoint inhibition, and I just discussed that, I discussed its rationale in the previous slides. We can also use tumor mutational burden, or TMB, or MSI, or microsatellite instability high, or mismatch repair deficiency, which we represent as DMMR, as other biomarkers of response to immune checkpoint inhibition. As genetic markers, TMB and MSI are more tedious to detect and may require expensive PCR or DNA sequencing techniques. Hence, PD-L1 is more commonly used despite some limitations related to specimen sampling and tumor heterogeneity. Since it is a protein, since PD-L1 is a protein molecule on the surface of cancer cells, it only requires immunohistochemistry, which is faster and cheaper for detection. Just to dive further into the topic, MSI and mismatch repair are related. Mismatch repair proteins are essential in correcting random DNA mutations that may occur during replication. And you see that in the illustration here on the left. If the cell's MMR system is defective due to mutations or epigenetic changes, this can lead to a loss of its gene editing function, and this can lead to more mutations. Most affected are microsatellites, which are short, repetitive sequences that you can see in this illustration on the right. So this, in this figure, you see here 6 CA base pairs that can be easily inserted with another pair of CA in the process of replication. So some DNA replication errors may occur, but with an intact MMR, the extra CA can be deleted and the original DNA sequence is preserved. However, if there's a deficiency in MMR, or what we call dMMR, the wrong sequence will be preserved, and the additional CA is incorporated into the DNA sequence, and this is propagated in daughter cells, leading to what we term as microsatellite instability. If there are more of these MSIs, this is what we call MSI high, and this can lead to translation of mutant proteins that are more easily recognized as foreign and therefore are more sensitive to attacks by the immune system. The immune attack is further enhanced by immune checkpoint inhibition. Tumor mutational burden, or TMB, is similar to MSI in the sense that with the presence of more mutations within the DNA coding region, more aberrant proteins are translated from defective DNA. And as in MSI high conditions, this will lead to more or to a higher chance of recognition by the immune system, which can be further enhanced by immune checkpoint inhibition. We have seen that there are some theoretical basis for using immune checkpoint inhibitors, especially in the presence of biomarkers. But do they really lead to better clinical outcomes based on patient trials? There are just so many studies on immunotherapies that I just had to select a few for demonstration purposes. The Keynote 042 trial was a study on first-line immunotherapy for treatment-naive stage 4 non-small cell lung cancer with PD-L1 expression of at least 1%. Patients were randomized to receive either pembrolizumab for up to 2 years or standard chemotherapy for up to 6 cycles, and they were observed closely until disease progression. The primary endpoint was progression-free survival, which is defined as the time from randomization to radiographic progression or disease from any cause. And the key secondary endpoint was overall survival. The study showed progression-free survival, or PFS, was significantly longer among patients who received pembrolizumab compared to patients who received standard chemotherapy. And the PFS advantage was highlighted in the subset of patients with PD-L1 expression of at least 50%. Looking at overall survival curves, we see more interesting results. Overall, we see that the study was positive since all patients with a PD-L1 expression of at least 1% had a hazard ratio of 0.81, meaning there is a 19% less likelihood of dying if patients are given pembrolizumab versus chemotherapy. In the same way, the graphs showing PD-L1 expression of at least 20% and 50% also demonstrated significant overall survival advantage of immunotherapy over chemotherapy. But notice that the hazard ratios seem to be getting better, as seen by a decreasing number as the PD-L1 expression increases. Because of this study, pembrolizumab received FDA approval for its use as monotherapy in the first-line treatment of non-small cell lung cancer with PD-L1 expression of at least 50%. Now let's look into another study on lung cancer. The Keynote 189 was similar to the Keynote 042 in the sense that it was for metastatic lung cancer patients who were treatment naive. But this time, they were randomized to receive either standard chemotherapy or the combination of pembrolizumab and chemotherapy. Overall survival and progression-free survival were also major endpoints. The combination of pembrolizumab and chemotherapy was associated with much lower hazard ratios for overall survival, meaning it was much better. And this was regardless of PD-L1 expression levels. And because of this, pembrolizumab received FDA approval for the use of combination or for its use in combination with chemotherapy in the first-line treatment of non-small cell lung cancer with PD-L1 expression of at least 1%. Now, there are just so many studies on immunotherapies for lung cancer alone. You can see in this figure the different clinical trials that have been conducted over recent years involving the currently approved checkpoint inhibitors. We see that the use of immunotherapy has been explored with or without the combination of chemotherapy in either squamous or non-squamous histologies using different biomarkers, and results are consistently favorable. In this table, I have summarized the landmark trials of immunotherapy for lung cancer alone. I'm using lung cancer here as an example because there are 4 different immune checkpoint inhibitors that may be used in different clinical scenarios involving lung cancer. As you can see in this table, you can use it as either monotherapy or in combination with chemotherapy or even targeted anti-angiogenic therapies like bevacizumab here. Most studies initially focused on metastatic lung cancer, therefore majority on the list are trials on advanced lung cancer. But recently, the use of checkpoint inhibitors in the adjuvant and neoadjuvant setting, as you see here and here, have been approved for early stage lung cancer, thereby showing how widely used immunotherapies are now. There are even indications for small cell lung cancer, as you see here and here. And this is just for lung cancer. Let's move on to this next table, which is not a complete list, but this just demonstrates that there are also clinical trials that have proven efficacy of immune checkpoint inhibitors across different and various cancers. Now, to help you become more familiar with these novel agents, here is a list of immune checkpoint inhibitors currently approved by the US FDA according to checkpoint molecules being targeted by the antibodies. And the ones available right now in the Philippines are the ones in the boxes. Pembrolizumab by MSD was the first, followed by atezolizumab by Roche. And recently, Astra's durvalumab entered the Philippine market. Now, you might think that these drugs are quite expensive and only a few patients might be treated with them, but you have to realize that there are patient access programs helping more patients avail of these medications, and the broad range of indications across all cancers are increasing, and more studies turning in positive results as time passes. Because of all these factors, we will be seeing a rise in the number of patients treated with immune checkpoint inhibitors. And as with all medicines, we must also be aware of adverse events associated with these checkpoint inhibitors. With the increasing popularity of immunotherapies, a new type of adverse events have emerged. And these are called immune-related adverse events, or IRAEs, which are actually autoimmune conditions brought about by a heightened T-cell response. And these may affect a broad range of organs and thereby may manifest in different ways. Now, the figure here on the right would give us an idea of what we may encounter in the clinics. For the convenience of the audience, this figure classifies adverse events as either rheumatic or non-rheumatic, and you'll see how varied they are. So as not to preempt the next speaker, I will not deal much on the management, although by nature of these toxicities, you can guess that they are mostly managed by either drug withdrawal or steroids. Let me just add that these toxicities may occur at any time and may even linger after discontinuation of treatment. However, most are mild and tolerable and occur mostly within the first 3 months of initiation of treatment. Perhaps one interesting piece of information I'd like to share before I end is that although IRAEs may be something to watch out for, they may also serve as a prognostic marker. 2 meta-analyses were done separately in China, and both were consistent in their findings. The first one, by the group from Wuhan, showed or demonstrated that the appearance of IRAEs was associated with better overall survival and progression-free survival. Similar results were reported by the group of Zhao from Beijing. In addition, regardless of type of AE, as you see here, or the severity of the AE, better survival and progression-free survival were actually seen in patients who had reactions to the treatment versus those who did not have reactions. So in conclusion, we have talked about how cancer develops in the context of immunosurveillance. And when we talk about immunotherapy, immune checkpoint inhibition is just one of the many strategies that we use. Specifically, immune checkpoint inhibitors block the suppression of T cells by inhibiting the inhibitor of T cells. And this leads to improvement in cytotoxic response of the immune system. Predictive biomarkers are very useful in selecting the right patients for immunotherapy, and these include PD-L1, and occasionally we also use MSI and TMB. We've also seen how immune checkpoint inhibitors have demonstrated efficacy in terms of overall survival and other clinical outcomes across different cancers and various clinical settings. They may not totally replace chemotherapy as the oncologist's bread and butter, but they are definitely taking center stage nowadays. And with the use of immune checkpoint inhibitors come the emergence of IRAEs that need to be recognized promptly and managed in a multidisciplinary setting in order for patients to derive the optimal benefits of chemotherapy or immunotherapy rather. So with the converging worlds of rheumatology and oncology, the rising number of cases, as well as the number of patients receiving immune checkpoint inhibitors, I hope to see more collaborations between our subspecialties in the future. Thank you for your kind attention.
Hello, I'm Dr. Kristina Rubio, and I'll be discussing rheumatic immune-related adverse events from checkpoint inhibitor therapy, balancing the immune response. I have no relevant financial disclosures. Immune checkpoint inhibitors switch off the regulatory signals that allow tumor cells to escape destruction by the immune system. They target inhibitory receptors and ligands on the surface of cells, such as CTLA4, PD-1, and PD-L1, leading to relatively unchecked T cell activation. In responsive patients, this invigorated immune response can lead to the destruction of tumor cells and regression of clinical malignancy. However, some patients experience an excessive immune response and off-target inflammation, resulting in immune-related adverse events. The clinical presentation of immune-related adverse events is varied and can affect virtually any organ system. The most common immune-related adverse events are dermatologic. Up to 30% of patients in clinical trials reported a dermatologic immune-related adverse event. Hypothyroidism is also quite common and has been reported in up to 20% of patients. For today, we will be focusing the discussion on the rheumatologic immune-related adverse events. There are multiple rheumatic immune-related adverse events that have been reported in literature. But in the interest of time, we're going to focus on the 5 most common rheumatic immune-related adverse events, namely inflammatory arthritis, polymyalgia rheumatica, giant cell arteritis, Zika syndrome, and myositis. There have been other reported immune-related adverse events with rheumatologic complications such as vasculitis, sarcoidosis, scleroderma, and even lupus. However, due to the limited time we have today, we won't be discussing them. So the prevalence of rheumatic immune-related adverse events is not well characterized in clinical trials. It's likely that they're underreported. Variable codes or grading systems have been used to describe musculoskeletal adverse events in clinical trials. Also, rheumatic immune-related adverse events are rarely life-threatening or severe. Therefore, they are less likely to be reported. Also, a lot of these rheumatic immune-related adverse events have non-specific symptoms that make rheumatic RAEs difficult to recognize. Inflammatory arthritis is the most common rheumatic IRAE and has a prevalence of 3 to 7% in retrospective studies. So we'll start with a case of a patient I saw a few years ago. She was 46, female, and diagnosed with metastatic melanoma. She was treated with nivolumab and ipilimumab. And nivolumab is a PD-1 inhibitor, and ipilimumab is a CTLA4 inhibitor. After about 3 weeks, the patient developed colitis and hypothyroidism. She was treated with high-dose steroids and thyroid hormone replacement therapy. Consequently, she did respond to the immune checkpoint inhibitor therapy, and her grade of response was partial response according to the RECIST criteria. When she was on maintenance nivolumab, she developed inflammatory arthritis after about a year. She presented with symmetrical polyarthritis involving the small joints of the hands and feet, as well as the ankles, elbows, and knees. Rheumatoid factor was negative. Anti-CCP was also negative. However, she had markedly elevated CRP and ESR. She was initially treated with prednisone and methotrexate, and when there was inadequate response, she was infused with infliximab, with only a partial response to this TNF treatment. Musculoskeletal ultrasound with Doppler is shown here, revealing Doppler-positive synovitis with erosion. So this is a picture of her talonavicular joint. Subsequently, she was treated with etanercept and experienced improvement. Up to about a year after starting etanercept, she reported that her arthritis was pretty well controlled and that she continued to have stable disease. So that's a case of a patient with inflammatory arthritis secondary to immune checkpoint inhibitor therapy. Inflammatory arthritis secondary to ICIs are clinically heterogeneous. Most patients will present with a small joint polyarthritis, sometimes in a pattern similar to rheumatoid arthritis. Some patients, however, will have larger joint oligoarthritis with or without inflammatory back pain. And there have even been patients who described a pattern similar to reactive arthritis, including also having conjunctivitis and urethritis. New onset psoriatic arthritis has also been described, but it's relatively rare. The type of inflammatory arthritis pattern may depend on the ICI exposure. Polyarthritis has been associated more with anti-PD-1 or PD-L1 treatments, while reactive arthritis-like disease has been associated with anti-CTLA4 or combination therapy. Reactive arthritis-like disease is also commonly preceded by colitis. Patients with inflammatory arthritis from immune checkpoint inhibitor therapy are commonly seronegative for the traditional autoantibodies such as ANA, rheumatoid factor, and anti-CCP. They also tend to be HLA-B27 negative. Inflammatory markers, however, are elevated in most patients. Imaging reveals synovitis, effusions, and erosions using both ultrasound and MRI. A paper reported that patients with HLA-DRB1 shared, or what's also known as the shared epitope, may have an increased risk of developing immune checkpoint inhibitor-induced inflammatory arthritis. Patients with inflammatory arthritis with RA-like patterns often evolve into a chronic condition, and this happens in approximately half of all affected patients. Another rheumatic IRAE that is commonly seen in patients is polymyalgia rheumatica. It's one of the most common inflammatory rheumatic immune-related adverse events. In fact, a pharmacovigilance study reported a 5-fold elevated risk for developing polymyalgia rheumatica with immune checkpoint inhibitor therapy versus cancer patients not treated with similar immunotherapies. Patients with PMR present much like patients with de novo polymyalgia rheumatica. They have hip pain and or shoulder pain and stiffness and elevated inflammatory markers. In fact, a study by Calabrese et al. Compared a group of patients who developed polymyalgia rheumatica secondary to immune checkpoint inhibitors and compared them with the EULAR-ACR classification criteria and found that 75% of patients with clinically diagnosed PMR from ICI inhibitors met EULAR-ACR classification criteria for PMR. However, 37% of patients required more aggressive therapy with glucocorticoids than is traditionally used to treat polymyalgia rheumatica. 20% received a glucocorticoid-sparing agent, with 2 cases responding well to the IL-6 inhibitor tocilizumab. So this is for the generalists in attendance. I just wanted to review the classification criteria for polymyalgia rheumatica so that you'll be able to identify this in practice. So patients with PMR present with morning stiffness lasting more than 45 minutes. They have hip pain or limited range of motion. They are usually rheumatoid factor anti-CCP negative, and they tend to have no other joint involvement. However, in patients in practice, and also among patients with immune checkpoint inhibitor PMR, they can also develop peripheral joint involvement. If you do have an ultrasound, you can use it to identify subdeltoid bursitis, biceps tenosynovitis, or glenohumeral synovitis in one or both joints. Required to apply the algorithm is that your patient needs to be more than 50 years old, have bilateral shoulder pain, and an elevated CRP or ESR. A score of 4 or more will categorize your patient as having PMR without ultrasound. And if you do use ultrasound, a score of 5 or more will categorize your patient as having PMR. So the next clinical syndrome that we've been seeing in patients who receive immune checkpoint inhibitor therapy is giant cell arteritis. So you need to consider this in patients who present with headache. So other symptoms that patients will experience are scalp tenderness, jaw claudication, visual changes, and they may or may not have PMR symptoms. Inflammatory markers were elevated in all confirmed giant cell arteritis cases from immune checkpoint inhibitors. And temporal artery biopsies did confirm GCA in these patients, and they showed intimal proliferation, arteritis, and disruption of the elastic lamina. Giant cell arteritis has been reported in patients who received PD-1 therapies, inhibitors, as well as patients who received CTLA-4 inhibitors. So a common symptom among patients receiving cancer treatment is Zika syndrome. And this is also a common immune-related adverse event among patients who receive immune checkpoint inhibitor therapy. They present with severe dry mouth and dry eyes, and most cases were negative for anti-Ro and anti-LAP. Oral cavities can show significant papillary atrophy with erythema and fissuring. And some patients will have reflectance, so this is shown in the lower left photo, from severe dryness, with inflammation seen on the palate mucosa. Myositis is an important clinical entity to be able to identify because inflammatory myopathies, while rare, can be life-threatening. Most cases present as polymyositis with no skin rashes. However, there have been several case reports of dermatomyositis-like disease in patients that received immune checkpoint inhibitor therapy. But it's not very common. So if you do have a patient with the classic skin rashes of dermatomyositis, you need to rule out a worsening malignancy with paraneoplastic syndrome. Patients will present with proximal weakness, respiratory weakness, and neck weakness. So we have another case of a 66-year-old Filipino female diagnosed with gynecologic metastatic adenocarcinoma of unknown primary in 2015. She was treated with traditional chemotherapy with stable disease until early 2019, but noted progression based on CT scan and increasing CA125. She was started on pembrolizumab, which is another PD-1, PD-L1 pathway inhibitor, and niraparib. However, on day 13, she developed progressive proximal weakness, described as having difficulty climbing stairs, carrying her groceries, and also noted diplopia and ptosis and difficulty breathing. The diagnosis at the time was inflammatory myositis from immune checkpoint inhibitor therapy, and they were also ruling out myasthenia gravis and myocarditis. So it's very important for clinicians to know the importance of the immune checkpoint inhibitor M-triad, which stands for myositis, myasthenia, and myocarditis. While these clinical entities can be distinct, they do tend to occur together. So you need to have a high level of suspicion in patients presenting with muscle weakness, with ptosis, and facial weakness. If you do have a patient with myositis, you need to look for the other features of the triad. So you need to check for troponins, do a 2D echo, cardiac MRI, and ideally you would have a cardiac muscle biopsy done to test for myocarditis. Significant risk of morbidity and mortality is seen particularly with cardiac involvement. In fact, the MD Anderson retrospective EMR review showed 36 patients with immune checkpoint inhibitor myositis, and the mortality for these patients was 22% overall. It was 42% in patients who had overlap disease. In fact, all patients who died had overlap disease. So going back to our patient, the following pertinent labs revealed a elevated creatinine kinase of 8,000. She was also seropositive with an ANA of 1:320 speckled. However, this was not checked before she was given immune checkpoint inhibitor therapy. So we don't know if she was actually seropositive before having received the immunotherapy. Her troponin I was 2.41, which is elevated, which could indicate a possible myocarditis. The acetylcholine receptor binding antibody was negative. However, her biopsy did reveal necrotizing myopathy, and the cardiac MRI and 2D echo were both relatively okay. They didn't show any worsening cardiac failure or myocarditis. She was started on high-dose prednisone, and there was some improvement. However, due to the only a partial response to high-dose steroids, she was treated with IVIG, and this led to marked improvement in her muscle strength, though there was some persistent dyspnea on exertion. Notably, even with just one ICI infusion, there was a partial response of her cancer with regression of the lymph nodes on physical exam and also on imaging. So ICI myositis is phenotypically similar to polymyositis, as you can see here. So this is a case report that was, a case series that was published a few years ago. And as you can see, it shows distinct proximal muscle weakness. There are, however, some patients who have isolated ocular symptoms or axial symptoms with sparing of the limbs. So ICI myositis does present with myalgia, a little bit more prominent than in patients with de novo polymyositis. They also tend to have involvement of ocular and facial muscles, presenting as ocular and facial weakness. Some patients may have relative sparing of the limbs, and when a patient has respiratory muscle involvement, then you need to consider possible myasthenia gravis as well. And of course, you need to check for myocarditis. The diagnostic tests you would order would be creatinine kinase, which is commonly elevated. MRI may show inflammation of involved muscles or fascia. The EMG is usually consistent with myopathy. Myositis-specific antibodies are mostly negative, and though patients can be positive for myasthenia antibodies, they tend to be the striational antibodies rather than the acetylcholine receptor binding antibodies. Muscle biopsy results are consistent with endometrial inflammation or show a necrotizing myopathy rather than dermatomyositis type patterns. So how are patients with IRAs treated? So in general, treatment is guided by the severity of the immune-related adverse event. The initial treatment for moderate to severe immune-related adverse events in general is corticosteroids at 0.5 to 2 milligrams per kilogram prednisone equivalent. If the patient does not respond to steroids, then you need to consider other types of immunosuppression. It's also important to note that baseline steroid use has been associated with worsened overall response rate, worsened progression-free survival, and worsened overall survival. Therefore, you need to be discerning when it comes to who you will start steroids on. So this is a proposed algorithm for the diagnostic workup and management of inflammatory arthritis that can occur with immune checkpoint blockade. So the first thing you would do would be to grade the patient's severity, symptom severity. Your first line treatment for mild joint pain is NSAIDs. And if that's ineffective, then you can try giving prednisone at 10 to 20 milligrams for about 4 weeks. If the patient has oligoarticular involvement or monoarticular involvement, then you can try intra-articular steroid injections. If the patient doesn't improve in 2 to 4 weeks, then you need to escalate to grade 2 management. And that includes referral to rheumatology and giving higher dose steroids, such as 20 milligrams, or even increasing up to 1 milligram per kilogram per day or equivalent if there has no response after several weeks. Finally, if the patient has severe joint pain, inflammatory symptoms, and limited ADLs, then definitely you need to give higher dose steroids and need to consider immunosuppressive therapy. For immune checkpoint inhibitor myositis, high-dose corticosteroids must be given because these patients do tend to progress quickly. In patients who have myasthenic symptoms and positive autoantibodies, then the next agent of choice would be IVIG or rituximab. For patients who have myocarditis, then you would want to target the cytotoxic T cells, histiocytes or TNFs. So you can give MMF, calcineurin inhibitors, TNF inhibitors. For patients with severe disease, you can even decide to give abatacept, which is a CTLA-4 stimulator, basically. But of course, you're worried about canceling out the effect of the immune checkpoint inhibitor therapy and basically reversing the tumor response of your patient. So these are the potential immunomodulatory or non-corticosteroidal agents for the treatment of rheumatic immune-related adverse events. So for mild disease, you can start patients on hydroxychloroquine, and then you can move up to sulfasalazine, methotrexate, or leflunomide. These agents are best used for inflammatory arthritis, and they are not thought to have a potential effect on tumor response. So for patients with inflammatory arthritis that are unresponsive to conventional DMARDs, then you can consider adding TNF inhibitor. TNF inhibitors are also the primary agent of choice after corticosteroids for the treatment of colitis, and you can also consider using them for patients with myositis. There is also not known to be a potential effect on tumor response when patients are treated with TNF inhibitors. For patients with inflammatory arthritis or polymyalgia rheumatica or giant cell arteritis, then you consider giving them tocilizumab. Patients with myositis and myasthenia gravis, you can consider giving IVIG. For patients with myositis with myocarditis, as mentioned earlier, you consider giving like phenylate or abatacept. So the long-term outcome of patients with immune checkpoint inhibitor immune-related adverse events is unknown. What we do know is that patients with inflammatory arthritis are at a higher risk of developing persistent immune-related adverse events. So this cartoon shows the possible mechanisms of patients, why they develop chronic immune checkpoint inhibitor-related, inhibitor-mediated toxicity. One theory is the smoldering inflammation theory, and this is very similar to de novo rheumatoid arthritis, wherein the immune checkpoint inhibitor stimulates a chronic inflammatory response that over time results in chronic arthritis. The burnout theory is due to destruction of the tissue by the inflammatory response secondary to the immune checkpoint inhibitor treatment. And this is the mechanism that is most commonly associated with endocrinopathies like hypothyroidism. But it can also explain the xerostomia that some patients experience after receiving immune checkpoint inhibitor therapy. This figure shows the possible incidence of development into subacute or chronic toxicity, depending on the ARAE. So the endocrinopathies are the ones that are most likely to develop into chronic disease, probably due to the burnout theory that was discussed earlier. Arthritis also has a high incidence of development into chronic toxicity. So what are the factors associated with persistent arthritis? And this study shows that patients with combination therapy, more than 2 additional immune-related adverse events, and a good tumor response have a higher rate of developing persistent arthritis. So it's also important to note that tumor progression and continued glucocorticoid use has been associated with mortality. So among patients who are being treated with steroids, it's beneficial for them for you to be able to get them off steroids as quickly as possible. So in conclusion, immune-related adverse events have varied clinical presentations. Rheumatic immune-related adverse events are rare, but likely underreported. Screening and referral to rheumatology will likely increase identification of patients with rheumatic immune-related adverse events. The chronicity of immune-related adverse events is higher with combination therapy, occurrence of more than 1 immune-related adverse event, and it's correlated with tumor response. And the treatment of rheumatic immune-related adverse events is possible while maintaining tumor response, but more studies are needed to determine long-term effects of concurrent immunosuppression. And these are some of the references I used for this lecture. And thank you.
Thank you. Thank you, Dr. Dennis Sacdalan and Dr. Krista Rubio. I enjoyed listening to your lectures very much. But for those who were not able to appreciate your lecture very well because of poor connection, then please watch out for us to post the recording of this webinar in YouTube. So I, for one, do not know very much about immune checkpoint inhibitors, but I have seen this mentioned in some of the guidelines which are being created for cancer treatment. And there are many such guidelines now being developed by the Department of Health. And so I would like to ask Dr. Dennis, you were mentioning about 3 available immune checkpoint inhibitors available in the Philippines. So I was just curious how extensive the use already is in the practice.
Well, yes, ma'am. It's becoming quite popular in the field of oncology because of the impressive results that we see in the clinical trials. Perhaps one limiting factor lang to its use is the cost of treatment. But as much as possible, if the patients that we encounter do really need it, and if it's really going to be very beneficial for the patients, that's what we would recommend. I think to answer your question, if it's widely used, I think it's quite popular, but again, the limitation really is with the cost. No? So if ever you're asking about how frequently we prescribe this, I think it would be very, very much frequent. No? But I can't give you an exact figure because not all patients would really be able to afford these drugs.
I can imagine how attractive it is for patients to think of the cancer being cured by stimulating their own immune cells, the T cell. But as you said, the limitation is the cost. Yeah. So it's something we have to work for.
Mm-hmm. Yeah, that's right. It's really quite attractive. That's why patients, when they consult me and ask about treatment, they'd ask about immunotherapies if it would be appropriate for them. And in several cases, I would say yes, but when we talk about the cost, then maatras na sila.
I have a question here from one of our attendees, and it says the checkpoint inhibitor clinical trials have active autoimmune disease as exclusion criteria.
Yes.
So how comfortable are you in using checkpoint inhibitors among those who do not have active disease? So probably some patients already with known rheumatoid arthritis who develops a cancer and the rheumatoid arthritis is controlled. How comfortable are you in using checkpoint inhibitors for these patients? And are there examples when you have used checkpoint inhibitors among patients with existing autoimmune diseases, and how did they fare?
Well, from personal experience, I have not yet treated a patient with autoimmune disease with immunotherapy. Well, maybe that's, I don't know if I'm still fortunate because I wouldn't be traumatized by such a dilemma, no. But if the autoimmune disease is not active, if it's controlled, then and if I believe the patient would truly benefit from this from checkpoint inhibitors, I might still offer the treatment to the patient, but I'd be up on my toes, no, and I'd really have to drag in the rheumatologist or an immunologist to work with me and watch out for the adverse events that may come out. Because remember the indications usually for checkpoint inhibitors are mostly for metastatic cancers.
Yes.
And when we deal with metastatic cancers, the goal of treatment is really to not just to prolong survival. Of course, cure is out of the question, but prolonging survival and preserving the quality of lives of our patients would be our main goals. And if on our assessment, giving immune checkpoint inhibitors would be more detrimental because of the adverse events, if it would make their lives more miserable, then I'd rather not give it. But if the rheumatologist says the disease has been controlled for quite some time, then we would consider it if as long as maybe you would clear the patient for treatment.
Me, I would like to say something about this question. Me,
Yes,
I would definitely clear a patient who is well controlled, who is on maybe only low dose steroids and stable immunosuppression for treatment with an immune checkpoint inhibitor. There is admittedly not a lot of data because, of course, as was mentioned, this is a great question. They do exclude these patients from clinical trials, of course. But in practice, when these drugs were finally approved in the US, they, of course, did have patients. You do know that, patients with autoimmune disease can have a higher risk for cancer, of course. So they can happen concurrently. And patients with stable disease, and they've only had several case series that I've read. There's actually a really good article that was just published, I think last year, a couple of years ago, compiling all these case series and reports showing that patients with pre-existing autoimmune disease actually have comparable response to immune checkpoint inhibitors as the general population. They, of course, can flare, but you would just manage the flares. It's hard to distinguish if it's a flare of their stable disease or a IRAE, unless, of course, the patient develops a different IRAE, then you know that this is an IRAE. If they had RA, but then they got colitis, then obviously our IRE na yan. But if the patient has just a flare of the arthritis, just treat the flare as you would treat a rheumatoid arthritis flare without the concomitant treatment with an ICI. Because as Dr. Sacdalan said, the outcomes are really dramatic. They're very encouraging. I remember when I was in med school, when you have melanoma, you're say goodbye, but these patients have really been able to survive years after their disease diagnosis. So, but in what Dr. Sacdalan mentioned is also very important. It really needs to be multidisciplinary. You need to select your patients very well. Patients on high dose steroids will have poor outcomes regardless. So I definitely, if the patient has active disease, if they have life-threatening autoimmune disease, then they're not a good candidate for immune checkpoint inhibitor therapy anyway.
Okay, thank you. Our questions are coming in now. And Dr. Pensurga is asking if these adverse effects are class effect.
Adverse effects are class effects.
The immune-related adverse effects, are they what we call class effects?
Sorry,
Yeah,
ma'am, I don't. Sige, go ahead,
I-
sir.
I'll take a stab at that. Yeah, I think it is a class effect because more or less all these checkpoint inhibitors, regardless of which molecule they target, have the same outcome, which is activation of the immune system. And so similar adverse events can be observed from or can be expected from any of these checkpoint inhibitors.
Yes, if I understand the question correctly, that's correct. And also, but interestingly, there are some immune-related adverse events that are more common with the particular blockade. Like if you're blocking CTLA4, patients are more commonly get colitis, or if they block, the PD-1, they're the ones who are more commonly present with inflammatory arthritis. Okay.
Okay, another question for Dr. Sacdalan. Thank you for the great talk. Are all these different kinds of anti-PD-L1 inhibitors in the Philippine market equal? And what is the incidence for the IRAEs for these different inhibitors? And would they also translate to the benefit as stated in the latter slides?
Well, to my recall, there hasn't been any direct head-to-head comparisons among these checkpoint inhibitors. So you can't say at this time if one is more efficacious than the other. With regards to the AEs, again, since there's no head-to-head comparison, it's hard to really say whether one drug would cause more side effects. It's what Dr. Rubio mentioned is really based on different trials, not just trying to look at all the results among all trials, but there have never really been any direct comparisons. But from the meta-analysis that I discussed in my talk, generally they do predict a better response to, as far as the tumor is concerned, they predict better response to the treatment.
Thank you. So this is another question for Dr. Rubio. If we use steroids, will it decrease the efficacy? Well, for both of you, whoever wants to answer, if we use steroids, will it decrease the efficacy of the ICIs? And how will you re-challenge patients?
So definitely, there's always a concern of suppressing the immune system when your goal is to, invigorate it. I think steroids is a reasonable treatment option for patients with IRAE because the idea is that you've already tipped the scale towards over inflammation because your patient is having an immune-related adverse event. So definitely at that point, especially if your patient has a IRAE that's life-threatening, you have to give steroids. There's no choice. But for the less life-threatening manifestations, we do start with, we try not to give steroids if we can help it, NSAIDs for just, joint pain. Depending on how severe the inflammation is, you can give steroids. We really don't know if it significantly decreases the efficacy, or maybe Dr. Sacdalan can answer that. But studies have shown that the longer your patient is on steroids, the worse the outcome in terms of tumor, in terms of tumor regression and overall survival. So I think that if you can get your patients off steroids quickly, that's more beneficial overall.
Yeah, I would agree.
Go ahead, sir. Go ahead, sir. Yeah, it's okay.
Yeah, I would agree with what you said earlier that there's not much evidence saying that steroids would actually cancel out the efficacy of checkpoint inhibitors. But of course, theoretically, you might think that, and that's been an issue. It's been a point of discussion among oncologists also. But at this point, we still do recommend using steroids in more severe adverse events because we just want to control these reactions and relieve the patients of symptoms that may be causing deterioration of the quality of life. So that would be the main role of the steroids. But as mentioned by Dr. Rubio, if you can withdraw the steroids as soon as possible and resume treatment, then that would be very beneficial.
Yeah, Dr. Sacdalan mentioned quality of life, and there's a really good study that was published in 2020, a qualitative study when they talked to patients with these chronic arthritis from ICI, and many of them described the severity of their arthritis being as severe as their quality of life when they had active cancer. So it's not something that you ignore. It's really something you need to manage, because of course you want your patient to live, but you want them to have a happy life, right, while they're alive. So you really need to address these symptoms that they're reporting.
It's really a balancing act.
Yes.
So thank you for that. We have another question from Dr. Abrahan. Thank you for your insightful lectures, doctors. And she wants to share a patient with breast cancer treated with pembrolizumab who had inflammatory polyarthritis and high acute phase reactants, but her anti-CCP was positive. And fortunately, she responded to low-dose prednisone and methotrexate. However, when the prednisone was eventually discontinued, then her symptoms recurred. So at the end, the question really is it likely that the condition burns out, similar to what we see in some of our patients with de novo rheumatoid arthritis?
Okay, so thanks for the question, Jane. The question is, we don't know, we don't have enough information about these patients because they're so few and the drugs are so new. But in a patient with anti-CCP positivity, it's likely that the ICI unmasked her underlying autoimmune disease, and she's probably going to have chronic RA. Studies have shown that patients with ICI induced RA-like disease generally don't become seropositive. So I think most likely she was already, she could have developed RA anyway, even if you never started her on pembrolizumab, and she will likely need chronic treatment. Of course, only time will tell once we get more data on these patients.
Thank you. And another question. For patients with history of IRAE, and you really need to give ICI again, is it a good idea to give steroids as a prophylaxis? Is it something that you do?
Is that something you do, sir?
No, in practice, no, we don't, because of the theoretical rationale that it might cancel out the benefits that you can derive from the ICIs. So we only give it when the adverse event is already there.
Yeah, I agree that you won't necessarily need to give steroids as prophylaxis. Also, because patients on baseline steroids, studies have shown that if you start the ICI, you have an increased risk of infection and overall worse prognosis. So if your patient recovered and then they're not on any immunosuppression and you think it's reasonable to re-challenge, normally I don't think you would need to start another steroid. I did have one patient that was mentioned earlier. She was re-challenged with, I think it was part of the protocol. After her colitis, they took her off steroids and then they gave her nivolumab and she was okay. There was years later, she developed another IRAE, but I don't think the steroids would have made a difference.
And I think for the last question, this is a burning question, and Dr. Krista, you were mentioning something about paraneoplastic syndromes, or was it Dr.
Yes.
Dennis who mentioned it? No. So how would we now differentiate paraneoplastic syndromes from these IRAEs? Is there a way?
I think you just need to use your clinical eye.
Yeah.
I think the pattern, as we know more about the IRAEs, we're starting to see that these patients tend not to be seropositive. They tend to have, if it's polymyositis, if it's myositis, it tends to be more of a polymyositis. than the DM type. And you know, from what we know about autoimmune diseases, of course, the ones that have already been classically associated with cancer, like systemic sclerosis, dermatomyositis, that really needs to be at the back of your mind, that maybe this is a paraneoplastic event rather than an RAE. You need to talk to your oncologist, how's this patient's cancer progressing. If the patient didn't respond to the ICI, then most likely it is a paraneoplastic event. And it actually makes sense for dermatomyositis also, because dermatomyositis, as we know, is more humoral, but it's more of an antibody-mediated disease. These ICIs, they target T cells, so then you expect more, if it's an IRAE, it's more of a T cell mediated manifestation. So that's how I would think of it in trying to distinguish.
Yeah, I would agree with Dr. Rubio. And from what I understand about paraneoplastic syndromes, they actually improve as you treat the patient.
Treat the cancer, yes.
Yeah, because when you treat the cancer, you prevent it from releasing these proteins that trigger the paraneoplastic
the
events.
humoral event, yes.
Because these are humoral in nature, and as you kill the cancer cells, and you tend to control these symptoms of paraneoplastic syndromes.
Yes,
And
I agree, sir.
maybe for the last question, I said it was the last before, but this is the very last question. Do you screen like before using ICIs? Do you screen for like autoimmune diseases to begin with, or maybe do a TSH? Is there already a protocol wherein you're advised to do that given certain groups of patients?
Well, of course, we before we start any treatment, complete history and PE is really essential in order not to miss out on anything. And so that's from there we can probably get an idea if this patient really has a history of an autoimmune disease along with the cancer. And there are some labs that we routinely take at baseline in order to make sure that later on as we go through treatment, we don't encounter immune-related events that may affect these lab results, such as your TSH and even liver enzymes, creatinine, because all of these can be affected by inflammatory events related to the checkpoint inhibitors.
Pero sir, yung ANA, RF, CCP, is that routinely checked prior?
Actually, no, we don't routinely check
yeah.
that unless we suspect that there is an autoimmune disorder. Then we'd refer to a rheumatologist and kayo na siguro mag-request.
But actually, sir, I was asking a while ago because interestingly, in the recent ACR, there was a paper that showed that it doesn't matter. ANA, RF, and CCP are not good predictors of developing an IRAE, so they don't look like they're good biomarkers anyway. But it's just because us rheumatologists are always curious if they ended up being seropositive after, were they always seropositive before? So that's really why I was asking. Okay.
And would someone with a family history of autoimmune disease be a person on whom you would need to screen those things? What do you think?
I think I would just screen, but watch the patient closely, because if the patient doesn't have active disease, even if they had an active rheumatic disease, I would personally clear the patient anyway if it was just mildly active. So just a history of family history of a rheumatic disease it's not a big enough contraindication, in my opinion, to ICI therapy.
Thank you very much. So this has been a very interesting discussion. Thank you, Dr. Dennis and Dr. Krista, for answering all of these questions, sharing. We hope to see you again on May 5 for another informative and timely lecture. Have a great afternoon. Don't forget to answer the evaluation form, and the link is in the chat box. Thank you, everyone.